Welcome to our attendees who have joined us today and to those joining via the recording to the North Simcoe Muskoka Specialized Geriatric Services practice short for October 2023. My name is Allison Jayawir and I'm one of the psychogeriatric resource consultants with the NSM SGS. I'd like to begin with a land acknowledgement. We're gathering on traditional lands sacred to many Indigenous nations. I'd like to acknowledge the traditional territories of the Anishinaabe, which includes the Odawa, Ojibwe, and Potawatomi nations, collectively known as the Three Fires Confederacy, the Haudenosaunee and Wendat nations, and the presence of other First Nations, Métis, and Inuit residing in the Simcoe Muskoka territory. Most of us have come here as settlers, immigrants, newcomers in this generation or generations past. We're all treaty people. As such, we commit to collaborating based on the foundational assumption that Indigenous peoples have the power, strength, and competency to develop culturally specific strategies for their communities. We're dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with all First Nations, Métis, and Inuit people. We're pleased to be able to provide our practice shorts through Zoom webinar. All participants are muted and videos are off. Please note that there's a chat box at the bottom of your screen for you to share with other participants and a Q&A section where we would ask that you write any questions for today's speakers. Please do not click on any links in the chat box unless they're provided by myself or Brittany O'Leary. Today's session is being recorded and will be accessible on the SGS website. If you're viewing the recording, welcome. And just a reminder that our practice shorts happen the second Friday of every month at 8:30 a.m. It gives me great pleasure to introduce Cameron and Beverly-Ann Oliver, who will be pouring over the 2023 AGS Beers Criteria Update. Cameron is a pharmacist with the North Simcoe Muskoka Specialized Geriatric Services, an assistant professor teaching stream with the Leslie Dan Faculty of Pharmacy at the University of Toronto. Beverly-Ann is a pharmacist with the North Simcoe Muskoka Specialized Geriatric Services and Geri MedRisk. Welcome, Karen and Beverly-Ann.
Hi all, thank you Allison for the introductions and thank you everyone for joining us today. Next slide, please. Our objectives today are to review the purpose of the American Geriatric Society Beers Criteria, outline the 2023 updates, and discuss practical takeaways. Next slide, please. We'd like to start with a very quick poll question to help gauge your familiarity with the Beers Criteria, as I know we have a large array of different backgrounds here today. So if everyone just wouldn't mind taking a couple seconds to answer the poll.
Beverly-Ann, I'm not sure if you're able to see the results. However, we've got 6% feel that they quite capably could give this talk. 80% have heard of it, and 14% are meeting you at the pub later today.
Okay, fantastic. Okay, thanks, Allison. Thank you, everyone, for participating. Looks like we have a wide array of answers in a diverse group as expected. So hopefully we have something for everyone today, whether that's a good introduction, providing some helpful tips or insights, or just highlighting a few of the important changes with the update. We don't have time to go through the whole paper or all of the updates, but we have also, we'll be putting the link to the paper in the chat in case anybody wanted to pull it up or save it for later to review or reference. Next slide, please. The Beers Criteria was originally developed by Dr. Mark Beers in 1991. It has since been picked up by the American Geriatric Society, who updates it every 4 years. So the last update was done in 2019. The updates are done by expert panel members, which includes physicians, nurses, and pharmacists. They use a defined, structured assessment process to determine the recommendations and the grade guidelines to determine the strength of the recommendations. The updates are done based on a literature search for new research that is focused on older adults, which they define as adults 65 years or older. Next slide, please. How should we use it? The goal of the Beers criteria is to reduce exposure to potentially inappropriate medications by improving medication selection in older adults. The key here is potentially inappropriate, not definitely or always inappropriate. It serves as a warning sign. One of the members of the expert panel compared it to a stop sign. You see the sign or the medication, you stop to look other directions. Are there safer alternatives? Are there non-pharms? If not, then can proceed when safe. This list is a guideline, but it still requires clinical judgment on whether it is appropriate to continue to use these medications or not. It is helpful to guide decision-making around medications. It's also important to remember that the Beers criteria can be used in all settings except for hospice and end-of-life care. Next slide, please. Thank you. So these next two slides include a general outline of the paper. Table 2 is the main table of potentially inappropriate medications. It lists the medications and why they are included, and I have an example in a few slides to help demonstrate. So then the tables become more focused. Table 3 is potentially inappropriate medications in certain patients with specific medical conditions, such as heart failure or delirium. Table 4 is medications to be used with caution, which stands out from the others because it encourages caution rather than avoiding. This includes medications or situations in which there's still an increased concern for potential harm, but do not warrant to avoid for various reasons. And this includes not strong enough evidence or the degree of harm is less so than the recommendations to avoid. Table 5 outlines some common drug-drug interactions that pose particular concern in older adults, such as additive anticholinergic effects or CNS depressant medications. Table 6 outlines some medications that are removed by the kidneys and may need adjustment in older adults due to higher instances of reduced kidney function. Next slide, please. Table 7 is a summary of anticholinergic medications, which I have also included an example to show you. Tables 8, 9, and 10 focus on the changes from the previous version, which is nice to help summarize what has been updated as a quick review. And Table 11 helps to give an idea on how to use the Beers criteria, which we will highlight as well. Next slide, please. So as mentioned, Table 2 is the main table which encompasses the potentially inappropriate medications. It sorts the medications by class and then provides the name of the medication. The intended indication states the reasons it's on the list and then what the recommendations are. The rationale for being on the list is very important to highlight as it helps to understand the recommendation and reasons for increased caution. Even if you are not implementing the recommendation, it can help to guide monitoring or discussion around use. Part of the table not shown is the quality of evidence and the strength of the recommendation, which are still two important considerations. So for example, on this section of the table that I have up, it lists warfarin for the treatment of non-valvular atrial fibrillation or VTE. And it states that it's on the list because it has been shown to have a higher risk of bleeding in older adults compared to DOACs such as apixaban or rivaroxaban. And but it has also shown similar or lower efficacy for these indications. The recommendations from the expert panel are to avoid starting warfarin unless alternate options such as the DOACs are contraindicated. But if they have been on warfarin for long term, then it may be okay to continue if there have been no adverse effects. Next slide, please. Here I have a section of Table 7, which is the drugs with strong anticholinergic properties. And this table is very handy as it pulls medications that are also mentioned in other tables, but they are medications that can have anticholinergic adverse effects and compiles them in one list. It's helpful as it's an easy and quick reference spot that can be looked over when considering new medications or when reviewing a patient's medication list, such as if you're looking under the antidepressants, and then you can quickly see medications such as amitriptyline or paroxetine. Okay, and now I will pass it over to Karen for the next slide.
Sorry, I was on mute. Thanks, Beverly-Ann, for the overview of the Beers Criteria article. So now I'm going to review some of the key updates to this 2023 version of the Beers Criteria. Next slide. Great. So there were many changes in the recommendations related to anticholinergic medications, which appear on various tables in the updated article. To avoid confusion, a summary table of the changes has been included in this update. So this makes it easy to find recommendations related to this class of drugs without having to look in multiple locations or tables. This is especially important as anticholinergics, anticoagulants are considered to be high-risk medications in older adults due to bleeding risk. You can see the recommendations related to warfarin, rivaroxaban, and dabigatran summarized in this one box. Next slide, please. A new addition to Table 4, which, as Beverly-Ann mentioned, is drugs to be used with caution, is the SGLT2 inhibitors. So that stands for sodium glucose cotransporter 2 inhibitors. So this class of medication is commonly used for the treatment of type 2 diabetes, but there's newer evidence for benefit in heart failure and kidney disease, which means that these drugs are likely to be much more widely used. The reason they've been added to Table 4 is the increased risk of urogenital infections and ketoacidosis in older adults. The recommendation is to monitor to recognize signs and symptoms of these issues early, and appropriate treatment should be undertaken with this class of medications. Next slide, please. Table 8 outlines medications that were previously on the Beers list and have been removed from the list in the 2023 version. So this is important because it also includes the reasons why medications have been removed from the list. And this is very important information, as you will see from the slide, that the reason for removal is typically due to low usage of the drug or removal from the US market. So it isn't that the medications are no longer thought to be potentially inappropriate. It's due to lack of use or availability. And as this is an American publication, there are some medications that may still be available in Canada, but have been removed from the Beers list. So an example of that, which is shown here on the slide, is methyldopa, which is still, although not very often used, still available in Canada. Next slide. So let's review the case of Lois, an 84-year-old female living in the community with PSW support twice weekly. As I read through the case, I'd like you to think about how knowing about the Beers criteria can assist you in your own practice in caring for this client. I'd like to request that you put your thoughts and ideas in the chat as we go through this case, and we'll have a couple of moments to discuss your thoughts. So Lois is referred to you due to weight loss and more frequent falls. She has type 2 diabetes, for which she takes linagliptin and empagliflozin daily. Empagliflozin is an SGLT2 inhibitor. She has hypertension. She takes hydrochlorothiazide 25 milligrams daily for that. She suffers from insomnia and self-medicates with diphenhydramine 50 milligrams at bedtime every night, which she purchases over the counter. For atrial fibrillation, she takes warfarin. And for occasional nausea, she takes dimenhydrinate or Gravol, 25 to 50 milligrams as needed. Think about your own practice or your role in the care of older adults. And I'd like to hear your thoughts about how the Beers criteria might help you in caring for Lois or someone like Lois. So I'm just going to pause for a moment while I give you a chance to put some thoughts in the chat. So I see a thought about looking for safer alternatives to highly anticholinergic meds. So thanks, Melissa. So diphenhydramine and dimenhydrinate both are have strong anticholinergic properties. So that may be concerning, particularly because she's having more frequent falls. You could use the Beers List Table 7 to help you identify drugs with strong anticholinergic properties. And I see risk associated with warfarin, so bleeding when someone is having frequent falls. So that's another great thought about relating this to the Beers criteria. So we'd have to, sort of explore a little bit further. If she's been on warfarin for some time, are there other concerns? Is she well controlled? Has she had episodes of bleeding? And I see Megna is also indicating that apixaban may be a safer alternative. So, now I'm getting lots of comments. So SGLT2, is that the best option for her diabetes management? Remember, empagliflozin is on the list for drugs to use with caution. And also considering some non-pharmacological treatment options for managing the insomnia, like sleep hygiene and so on. So great. So thank you all for your comments and participation. I see there's lots more. I'm not going to have time to discuss them all, but the goal here really was to get you to think about how knowing about the Beers criteria can assist you in caring for someone like Lois. So I think I'll move on to the next slide, please. So you've had a chance to think about a case example. So I would also encourage your thoughts about other clients that you may see and how the Beers criteria may be helpful, how you can apply that to other areas of your practice. Okay, next slide, Allison. Thank you. So this is what the authors of the paper think. So this is how they envision that the Beers criteria should be used. So the first point is to remember that medications on the list are potentially inappropriate, not definitely inappropriate. There are situations where a medication on the list is still the best option for an individual older adult. Understanding why the medication is on the list helps with the assessment of appropriateness. And thirdly, the next point I think is key to everyone who is part of a healthcare provider team, whether regulated healthcare professionals or not, that simply identifying a potentially inappropriate medication is important. So if your scope includes making an assessment as to whether or not it's appropriate for that individual, then you can make a recommendation for a safer drug or non-drug option. Next slide. Here are some of our additional thoughts. If your role includes med assessment, then you can identify potentially inappropriate medications and symptoms that are commonly caused by PIMS, as PIM is the abbreviation for potentially inappropriate medications. So examples are falls, dizziness, dry mouth, and so on. You can identify drug and non-drug alternatives to PIMS. So, for example, alternative treatments for insomnia that can be recommended if appropriate. And if you're a prescriber, then you can discontinue or taper the potentially inappropriate medications. If your role doesn't include medication assessment or prescribing, which I suspect maybe many of you in the audience today, then simply having an increased awareness of medications or classes of medications that are on the list is a really great contribution. So knowing the reasons why medications are on the list, for example, they cause bleeding or falls or dizziness, this will allow you to identify signs and symptoms that may be caused by medications. So that the sign or symptom can be reported to an appropriate member of the healthcare team who can then make an assessment as to the appropriateness of the medication. Next slide. Here are some resources for you. So the first resource is the one that's been put in the chat previously. It's just a link to the actual Beers Criteria Update paper. So you may find that helpful as a resource with all the tables and all the drugs listed. The second reference, which Brittany has just put in the chat, includes some handy tools and pockets cards that you may find useful in your practice. There is a fee to purchase some of these tools, but I'm just putting it out there for your information if you think that would be helpful. And then reference 3 is the stop-start criteria. So this is another paper, a list of potentially inappropriate medication that is a European-based guideline. So remember, the Beers criteria is an American guideline. The stop-start is based in Europe, and it was recently updated in 2023 as well. So in addition to having their lists of potentially inappropriate medications, they also include a list of drugs that may be indicated or should be started in older adults. So the link to that is on the slide as well. And you can also easily find any of these papers just by doing a quick Google search. Next slide, please. So we recognize this is a very brief overview of Beers criteria and the 2023 updates, but hopefully there is something that is of interest to everyone and that you can take away even one piece of information or tool that you can apply to your practice. And now we'd be happy to take any questions. I think we have time.
Wonderful. Yes, we do, Karen and Beverly-Ann. Thank you so much again for such an incredibly succinct and thoughtful presentation. We do have one question in the chat box currently. It says here, great presentation. Thank you for the clarification on why medications may be removed from the Beers list. Practically, how do clinicians keep track of drugs that are still potentially inappropriate medications?
That is a good question. So I think, you know, depending on your role, there's different strategies that you can use. For myself, you know, a lot of the medications have been on the list for years. So over time, you do get to know drugs or classes of drugs that are concerning. So anticholinergic, we've highlighted a number of antidepressants, drugs that cause sedation. So those are things I tend to sort of group them that way. Drugs that cause bleeding. So if we think about our older adults and their common presentations, problems, or conditions, then it's sort of an easy way to attribute drugs to those conditions. You know, to be honest, like I have a paper copy. I'm a bit old school, but I just have a paper copy And if I'm not sure, I just flip to the table and refer to it. I think also that's the reason why some people like the pocket cards, because they're quick reference tables. So, if you don't want to carry around a big multi-page paper with you, some of those tools may be very helpful for remembering as well. So hopefully that answered your question. I don't know, Beverly-Ann, if you had anything that you wanted to add from your own perspective.
Yeah, my thoughts were exactly on the same line as yours. And I think when it comes to the drugs that are being removed from the Beers criteria, none of them were extremely concerning in the fact that I see them every single day and they're extremely common. So I think that's one thing that kind of helps as well, that even if they are still available in Canada, a lot of them are low use, but having the list only be updated every 4 years, you kind of get familiar if you review it when it comes out. And but I also think what Karen said with grouping them with the classes helps. If you understand that this medication may cause drowsiness and you don't see it on the Beers criteria, or when looking it up, you think you see the side effects and they're anticholinergic, but they're not on the list, it just kind of highlights an awareness for the class effects. And then in general, you just have a little bit more caution.
Terrific. We don't seem to have any more questions in the Q&A. However, I'm pretty sure Beverly-Ann and Karen would be open to questions if you wanted to reach out to them, or through the PRCs, you can certainly reach out. I just wanted to thank you once again, Beverly-Ann and Karen, for such a great, succinct talk on the Beers list. I know each of you could probably speak for the full day on it, or probably the full week, knowing your knowledge in pharmacy. So thank you again, and I do appreciate the succinctness. So wanted to draw your attention to next month's practice short. So November's practice short will be with Jill Strachan, who's a registered nurse with our geriatric medicine team with the North Simcoe Muskoka Specialized Geriatric Services. She's going to be offering some practical information on diabetes risk assessments applicable to all of us. The registration link is being added to the chat box at this time as well. So that's next month. And as always, we wanted to inform you of some upcoming education sessions. Specifically, we're having a positive approach to care course coming up in Collingwood on October 31st, and really looking forward to seeing folks in person there. We're adding the link to our education page to the chat box. Please, if you think maybe you might be able to attend, it would be lovely to have you there. Our seniors mental health course is coming up in November as well, so keep an eye on that as well. Thank you all, and have a wonderful rest of the day.